Welcome to AI Rounds, where we explore the intersection of AI and healthcare. I'm Dr. Anil Jain, Chief Innovation Officer at Innovacer, and I'm joined by Michael Hahn. He is the Chief Medical Information Officer at MultiCare Health System. And we are also joined by Brendan Keeler, who is the Interoperability Lead at HDD Health, and Lisa Bari, Head of External Affairs at Innovacer. Together, we'll be unpacking the latest developments in health AI and their implications for providers, patients, and the industry at large. Team, let's start with the recent CMS listening sessions for the health tech ecosystem RFI. CMS announced several new initiatives, including a national healthcare directory, adoption of digital ID solutions, support for a digital insurance card, and CMS data at the point of care API. Now, some of us responded to the RFI earlier this week, and two of you were actually in DC for the event, Lisa and Brendan. Well, Lisa, we'll start with you. Tell us what you heard and what it tells us about the direction of this administration.
Yeah, thank you for that. And I will also just note for the surely legions of loyal fans of this show that the last time I was on this show, I did not work at Innovacer. And in fact, it was not clear that I was going to be working at Innovacer, but now I do. So in my new role as head of external affairs, I'm working on policy and government relations and all of the various other things. So very exciting
welcome,
to be here.
Lisa.
Thank you. Thank you. As an Innovacer employee. Exactly right. I don't know, a month and change ago, CMS released this massive request for information on the health technology ecosystem. And, just in reference to this show right there, are certainly aspects of that about, innovative technology, AI, and things like that. And then kind of right after they released this behemoth of an RFI, they invited some people to come to DC and to, I guess, have a listening session about the RFI. And I don't know, Brendan and I were both there. I don't know if we necessarily knew what to expect, but it was definitely interesting. We got some, podium presentations from key HHS leadership, including the secretary, including the heads of the HHS agencies. It was really kind of unexpected for that kind of approach. I will say the stars of the show, the people who really did all the work, were the senior technology advisors. Amy Gleason, who was also the head of DOGE, which in all reality is the US Digital Service, and Arna Cara and Alberto Colon Vieira, who are both senior technology advisors to CMS, to the administrator, to Administrator Dr. Ross. And so there were some panels on stage. Brendan was on the main stage, cutting it up as far as I could tell, having some debates in real time with Kristen Valdez from Be Well. And then there were breakouts as well on different topics. So it was quite an event all day. And I don't know that we heard anything terribly surprising. Right on stage in the beginning of the listening session, they talked about the things that they were going to do. And you mentioned them already. They were these the continuation or promising to finish this work on national provider directory, and then a bunch of other stuff that wasn't really huge in nature. So that's kind of my high level take. Brendan, jump in, tell us how you experienced it as well.
Yeah, and also tell us what you spoke about on
Yes.
the main stage there.
So yeah, it's a great summary. One meta theme that I think is worth pulling at is it was kind of rough around the edges. It was rushed to put together. It was we're having prep calls over the weekend for the panel. They told me last minute that I'm hosting one of the breakouts with that's not how government always operates, right? Government is polished and process and all the trappings.
Which government are you referring to, Brandon?
yeah. Well, it is slow to put everything together, and so I found it encouraging. I found encouraging that they said, "Let's go do a really quick RFI. Let's go get quick alignment from the agencies." In kind of this funny way, like RFK coming out 15 minutes late and stuff. But it was all there to say we're aligned. We're going to move fast. We're going to move fast on this. We're not going to wait for perfection, and we're going to go and put things out into the world. And so you break down those 5 updates, and some of them are them signaling, "Hey, please comment about these. We're going to do something here, and you should tell us how far to go in one way or the other with the directory, or how far to go with the trust exchange networks. Like, what should we actually do there? Is it DEFCA or something else? They were like, with those announcements, they're inviting comment. Others are very practical. Like the DPC API has existed. I was in the pilot like in 2019 or 2020, and
Right.
then it's just been paused. And they said, well, let's do this. Let's actually go for this, because this piece of technology is stagnated and been wasted when it has the chance to enable physicians at the point of care. So both pragmatic and tactical, and also like steering without telling, right? Saying, hey, we're going to go do this, but like, please tell us via the RFI, which was exceedingly broad and invited every stakeholder to weigh in on almost every angle of technology. So I'm excited to see the comments come in for it, because the comments thus far have been a bunch of trash. And so, you have Redditors coming in and talking about like Counterpart Health by Clover Assistant, the leading co-pilot for Medicare beneficiaries, according to a number of Redditors. You have a lot of like patients and providers commenting who are mad, but like most of the ideas boil down to like one PHR to carry around your information, or a big EHR, one EHR to rule them all. So not really a bunch of tactical policy suggestions, but a few gems. And I think we're generally with these things, the best comments like innovators are right towards the end. So I'm excited, and this is nonpartisan, right? This could
Yeah.
easily be a very partisan. This is the Republicans, and I didn't get that out of the event.
Well, that's great. So, for those who are watching the show who may not be familiar with what it means to have a listening session, it's not the people who show up that are listening. It's supposed to be CMS that's listening. Is that fair?
Yeah, that's fair. I mean, so there's sort of the administrative process of public notice and comment, which is a regulatory structure. This isn't a regulatory action; it's sub-regulatory, if you will. They're just requests for information, tell us stuff. And this is what I always tell people, technology folks, otherwise. You can talk to the government. Brendan is a great example. He does it all the time on Twitter, X, in all other ways through formal methods. You can tell the government what you think, and the more specific and qualified your comments are, they actually listen, because they genuinely need insights from the field. What is it really like to do this work? If you're in a clinical setting, what is it like to do this, with patients directly? What is it like to build technology? What is the problems you experience when you're trying to actually integrate with X, Y, and Z EHR? They need to know specifically so they can make sure to write rules and regulations that support, or not write rules and regulations that harm what you're doing, et cetera, et cetera. They need details. So this process. This is still the very like sub-regulatory part of it, but generally they're here to listen. And again, you got to delete all the political things, all the partisan things out of your mind. That's not what this is about necessarily. You have to kind of, in some ways, ignore it, because there are people there who have a job to do, and they may be operating under a particular political administration, but like there's still a fundamental job in operating things that HHS and CMS have to do, like legally, to run one of the biggest insurance companies in the world, basically. So
Well, I think you said it. I think you said it well. That much of what we're thinking through when it comes to the kind of responses that CMS is looking for are absolutely bipartisan, and the fact that it has to work in the real world. It cannot work just on a regulatory piece of paper. Now, Michael, listening to Brendan and Lisa talk a little bit about the CMS listening session, discussing a little bit about how the sausage is being made, if you will, in terms of how the various rules and the realities of implementation get discussed. Any thoughts, any comments that you'd like to make?
Yeah, I think that the first is it's a little bit scary, right? In that it was rough around the edges, not really well organized, right? But on the other hand, it's a little reassuring in that the government's not gonna it doesn't feel like the government's gonna get in the way, and that it was very pragmatic and tactical, and I'm really reassured by the fact that it was a sort of bipartisan. Let's do what's best for the patients. Let's do what's best for providers, and try and solve problems. as opposed to let it devolve into the partisan rancor that seems to grip Washington fairly routinely now. And so yeah, it's scary, but also sort of reassuring, because I think that this is a space where government doesn't necessarily have the expertise to impose regulations. And Anil, you're going to laugh, but in the operating room, we would routinely say, perfect is the enemy of good, right? And we don't want to let perfection ruin all of the important things that we can get done that may be just good enough to improve the overall patient experience as well as provider experience.
I think that's a perfect segue. It's really around not just the letters of the rules that are being written, but the implementation side of it, the reality, and perfection can sometimes be elusive. It really raises an interesting point. And we all know Mickey Tripathi. He was the former ONC head, and he's taken on this new role, this Chief AI Implementation Officer at the Mayo Clinic. So congrats to him in what he's accomplished and this new role, and we wish him all the luck in the world. It's becoming clear, though, that health system C-suite folks are expanding. There's new titles. Sometimes they're battlefield promotions. Sometimes there's new blood from other industries being brought in. And we're seeing the Chief AI Officer position becoming, I won't say, ubiquitous, but it's becoming more and more common as we see different health systems, and we're seeing vendor organizations as well having a Chief AI Officer. So, Michael, you talked about, let's not let perfect be the enemy of good enough, and the word implementation is a key word in Mickey's title. Tell us, what do you think about this new role of a chief AI officer, and then maybe you can also talk a little bit about adding the word implementation. You had some very interesting thoughts in our prior conversation.
Yeah. So we, with the release of ChatGPT 3.5, back in 2022 is that, I think that's right, like the end of 2022, and there was
back in the old days,
right? The hoopla, right at the turn of the year, right? And we quickly named a chief AI officer, and it was just like Anil said, a battlefield promotion. And I think that it was, number one, it was, is it secure? Is it safe? How can we preserve our reputation? Because our executive suite were literally hearing stories of this could be like taking a flamethrower to your brand, and then it morphed into, okay, we have a process, and we're going to create this governance that sort of sits around it, and I think that was that sort of chief AI officer 1.0, right? And I love what the Mayo Clinic here has done in terms of adding in the word implementation, because I was at a venue a few months ago, and the question was posed to a group of CMIOs, what is the biggest challenge facing AI in healthcare? And it was, and the number one concern was adoption, right? And it's, again, if you implement this really cool AI tool yet nobody uses it, it's like the proverbial tree falling in the forest. And so how do you get implementation? How do you get adequate adoption? And if Mickey is really focused on the implementation of artificial intelligence tools, then I think that this is a great play on the side of the Mayo Clinic. The other side of this to me is what tool is not going to have artificial intelligence associated with it at this point, right? I mean, every technology tool, and be it a legacy tool that we've had in our system for years, or a bright shiny new object, is going right now has AI that's attached to it. And again, there's various forms of AI that are out there. And so when does this become redundant with your chief digital officer, your chief innovation officer, your chief information officer, your chief technology officer, or all the above, right? I mean, so I'm curious as to how long this will be a separate role, but in the now, I think it's a cool play by the Mayo Clinic.
That's great, Michael. Lisa, certainly very interesting dynamics in the boardroom. with the
Yeah.
CEO having counsel now from a chief technology officer, chief digital officer, chief AI officer, and now a chief AI implementation officer, just as Michael was explaining. So, what are your thoughts? Is this the right time for us to be thinking about a chief AI officer, and what are you seeing out there?
Yeah, I mean, I also I agree with Michael. I think it's getting interesting here. Who are they going to be taking sort of counsel from? I do think this goes in cycles from sort of a corporate structure thing where the titles expand and the titles contract. And there is some inflation here, right? At the same time, I could imagine things sort of centering around someone who's leading, AI and technology innovation in general over time. But again, I do think we might also be in sort of a corporate cycle of title inflation and adding new titles, and then we might kind of bring it back together. I also agree with you, Michael. I think that, it doesn't make sense to think of AI, whatever that means, like writ large as like this standalone thing. It's not an amorphous thing. It is a feature and functionality, and also a way of developing and delivering tools in existing systems. I think that's important. Well, spoiler for in a little bit when we'll talk about how some companies are doing better or worse at, evolving their products with this new reality.
Yeah, Brendan, I mean, AI governance for health systems, especially complex health systems, must be incredibly difficult. Both, I think what Michael alluded to was sort of a defensive posture for the chief AI officers, as well as an offensive posture as they try to solve problems. Any thoughts about this from your point of view? What advice would you have for these chief AI officers? Should they be following you on Twitter or X, or
Look,
watching?
if you want people shilling their own shit, you have to go to the RFI comments, because that's where you'll find it. Not here, but so I will not shill my own shit, but my own stuff for if we have to edit that. What I will say is, if AI is the technology that is the most promising technology of right now, and it is also some of the highest upside and downside risk, and it requires specialized expertise, then golly, you better have an executive leader who's intently focused on just that. And it may be subsumed, or maybe that leader is your chief innovation officer, your digital transformation officer, or whoever, if they have that skill set and understanding. But it's not so simple as to say, here's an ambient scribe, how do we integrate it? It is everything we're doing is under assault, is by the potential of AI. The chance for agents to take over roles, the ways that we integrate with EHRs, the ways that we we supplement and make decisions. Like, these are really heavy duty things. So to understand it immensely and build the infrastructure to make the right choices seems to be like the highest importance for health systems and most organizations. So I don't, if a title of that magnitude is what it takes to get a person of the caliber and quality of Miki Tripathi to shepherd that for one of the most important healthcare institutions, then it makes sense to me.
Great. One of the things that these chief AI officers will need are tooling for benchmarks, right? Everyone is out there trying to figure out, how do we measure the impact? How do we measure the quality? How do we measure what these different tools are doing? And recently, we all saw the headlines that OpenAI released a project called HealthBench. And this whole idea was to evaluate how various AI systems perform. And I'll use the word realistic in quotes, because we'll get to that in a minute, but how they might perform in a realistic health conversation that might be occurring between a patient and a doctor, or between a patient and a allied health professional, or whatever it might be. It was built in partnership with, get this, a whopping 262 physicians. I don't know how many physicians there are in the country. Michael, you
It's
probably
not
know.
just the country; it's globally. It was meant to be a global cross section.
Right, exactly. So we've got a pretty good end there, I think. And HealthBench includes something like 5,000 realistic health conversations. I suspect, Michael, at Multicare, there are probably about 5,000 conversations happening in one clinic session across the various facilities. And I think they did come up with an interesting rubric. And whether you look at some of the comments that were being posted soon after they released it, in terms of whether This is going to give developers and others a false sense of security because of the low end. None of us, if we were doing a clinical trial, would rely on this kind of sample size. We also don't know, back to the implementation comments that we were making earlier, we don't know what's going to happen in the real world when you start having human beings reacting to AI agents and AI chatbots. So we can make some assumptions, but we certainly don't know for sure. We also know that there were some early syntactical mistakes made on the project. But I'd like to get your reaction to this, because it is, while it's really, really important that we think about benchmarking in AI, the idea that a company would police itself and release their own benchmarks for their own work is interesting. But Lisa, who are they targeting? Who is HealthBench for? And how useful will it be?
For anyone who's trying to value OpenAI beyond the foundational models, that's just my snarky answer at first. But I think they're trying. I think they're trying to create, have a product approach to healthcare and health AI, understandably. But you already heard from my snarky comment and kind of the looks on everyone's faces that we're not super impressed, and that there have been some issues pointed out with this. It's obviously very hard. It is very, very hard to come into healthcare from not healthcare, especially on the data side, on the technology side, and do something meaningful, even if you have good partners. I like the idea. I just don't think this was big enough, and I don't know that this is necessarily the right way to approach it, right? I think we'll talk a little bit more probably in a bit about the product side and who's doing product well in this space. But that's also it's also been noted as a risk for health tech innovators who are working with some of these foundational model companies, where I forget what there's a term for it, where you build something, you're working with one of the foundational models, and then they go and do it and scoop you and steal your business, quote unquote. That might be okay and plausible in sort of the consumer technology space for things that are very light, but man, healthcare is hard. Ask me how I know, right? It's not for tourists, I would say.
Yeah, no, that's a great point, Lisa. Brendan, this OpenAI Health Bench. Any thoughts about it? What are you seeing and hearing from your community at large?
Yeah, a couple of thoughts. Open source is good, right? And so it contributes, it advances the ball. We're going to continue to see groups, both verticalized groups like Epic releasing their benchmarking and validation tools a little while ago, and then this, like from a horizontal company. I agree with Lisa. Just from a strategic perspective, you're OpenAI. You are now a consumer company, right? Like now a preeminent consumer company up there with Google, right? In terms of consumer brand and usage. You're an infrastructure company, a horizontal infrastructure company with APIs and things like that. That's a tension right there, a business tension, that you are still a startup, a well-funded startup, but competing against the largest giants in the industry. And then you go and make more verticalized solutions already, infrastructural solutions. There's just a number of tensions and expertises that you need all simultaneously, all at once. And sure, you have a lot of money, but those frontier models cost a lot of money too. And so I like bubbling back up to just like a corporate strategy. I'm like, okay, sweet, you're proving you can do things, but its focus still matters for startups of every kind, especially when the stakes are so high, given who they're competing against. So I think that's an interesting facet. I don't think it has long-term legs without continual investment, and so I think they'll kind of lose interest, and we'll see some other benchmarks get picked up and put out there that might be better.
How do you both see how the FDA might be receiving this? Thinking about it's tough to regulate AI algorithms because they're constantly evolving and learning, and some of the models that we typically, Michael and I, have seen for clinical trials and clinical research are not going to necessarily work in AI, and the FDA's kind of made that clear that they're going to treat this a little bit differently, and software as a medical device kinds of rules and regulations exist. But when companies put out benchmarks like this, are they basically trying to send a message saying we're going to start to police ourselves and please don't get involved? Is that the way you're interpreting some of this as well? Lisa?
That is definitely the way that I would interpret it. Obviously, this is the constant back and forth between industry and the regulatory government, right? Is, we're going to regulate you, don't regulate us, we'll do it ourselves. And, it always has to be somewhere in the middle ultimately. But I do think putting something like this out there is trying to show like, look, we have a plan. Now, I will say, at least historically, the FDA has been probably the furthest ahead of the regulatory agencies on, regulating anything involving AI. As you mentioned, software as a medical device has been a concept for quite some time. Now, of course, many of the HHS agencies lost a lot of staff, people with tremendous amount of experience in the space. So I don't know the current state of that, but historically, in recent history, FDA was pretty far ahead of understanding what's going on and really not being, you can't just casually say, don't worry, FDA will regulate ourselves. That's not really worked. So I do think this is a signal to say, look, we have the ability to, publish these benchmarks and things like this. How it will land with the FDA, who only recently, got a new lead, and Dr. Makari is, remains to be seen. I would say it's still too early to say. That's my take. I don't know, Brendan, if you agree. That's how I view this kind of back and forth.
I wish we could do self-regulation. Like that actually exists in other industries, right? There's a bunch of finance and banking self-regulating industries that actually have teeth and police the industry. I think healthcare, we've been pretty bad at that. So yeah, I agree with you. That we're going to see since 2 administrations ago, the FDA and ASTP, there's been this sort of back and forth, where's software, where's the line? And AI adds a new dynamic there that we're going to have fun with, right? Like agents versus co-pilots. What level of clinical decision making? When do you trigger the software as a medical device? I think it's going to be tested as there's abuses and failures, and there will be abuses and failures because we're headed into a new era where I don't think it necessarily is malicious, but people will overstate what they can do, and there'll be accidents and consequences, and that's when regulation becomes necessary and warranted and good, is in the face of the concrete facts of abuses and failures.
Yeah, no, that makes a lot of sense. I think, Michael, hearing what Lisa and Brendan are sharing, and then just thinking about, an organization like OpenAI putting benchmarks out there. When you think about the broader strategy as a CMIO, thinking about whether you're going to procure a set of tools or you're going to have your teams build a set of tools, having these published benchmarks with all the caveats that we discussed in terms of weaknesses, is this help organizations like yours make those kinds of decisions?
I've learned so much just listening to Brendan and Lisa, because at first blush, right? I mean, when I was looking at this, I was like, oh, this could be pretty cool. Maybe this could be like a Morningstar report for AI tools, right? And so when we look at these sorts of tools, I'm always looking at it in sort of a build, borrow, buy framework, right? And multi-care is not big enough to build a lot of these tools on its own. But if we did get an itch to do that, my first question is where in the order of operations does this land, right? Does it land before I validate on my own data, or does it come after I validate this on my own data? And so in terms of the borrow, right? I mean, we generally have to rely on our vendors to validate these tools. Could this be the part of the validation? Maybe. I mean, again, I have a significant concern regarding the N of 262. It seems awfully small. Considering that there's, just, at an institution like multi-cares, that's not huge. We have an order of magnitude more physicians than what they've tested on, right? And then, the buy. Right. So there's a large number of healthcare institutions out there that aren't even in the borrow category where companies like Innovaccer are willing to partner with them. You're buying off the rack, right? I mean, you're buying off the rack, and you're getting what you get. And so for those smaller healthcare institutions, I do think that having this sort of I don't know, underwriter laboratory stamp of approval, or Morningstar 5-star, right? I mean, something along those lines where we can say that, yeah, this is transparent, this is responsible, this is safe, this is and we think that you can go ahead and implement this in your environment. Because there's going to be a lot of smaller healthcare shops that do need that help. I think that their heart's in the right place. The execution, we'll see.
Yeah. Yeah, I do, healthcare, we have been plagued by benchmarks because we typically measure what we can, and all the things that really matter, we have trouble measuring. So my only hope would be that as we think about benchmarks in AI, that we really take on the tough problems of measuring what matters as opposed to what's easy to measure. And I also want to make sure we're looking at the right gold standard or the right comparison group. I mean, if you took 5 docs and put them in a room and listened to a patient's conversation and asked them to summarize what the patients told them, I don't know how consistent it will be with each other. There'll be 5 different stories. That's exactly right, Michael. And so I do think that we sometimes ask AI to do more than we ask our physicians and our healthcare professionals.
Well,
But
this brings up a particular saying, right? Compare me to the alternative, not the almighty.
yeah,
Which is, I mean, I don't want to give AI, again, very amorphous term, a break. I want AI to be better than humans, fallible humans, but that's a high standard, man. That's a really high standard.
Right.
yeah. I always. I'm sorry. Go ahead, Michael.
I mean, I talk about this all the time. Do you need it to be better than the median physician?
Right,
Do you need it to be
Which
better than
one?
do you need it to be top quartile? I mean, when it comes to self-driving cars, do you want that self-driving car to be top quartile, or do you want it to be median, or do you want it to be perfect? And I would say that I want it to be better than a 16-year-old teenage boy driver, right? I mean, who in general, they're not very good. They think they are, but they're not very good drivers, right? And so if you're better than if you're in the top quartile, I think that you should be pretty safe. And I'm sorry I interrupted you, Anil.
No. I think it's an interesting conversation because when we think about benchmarks, I always ask myself, what's the comparison group? And it's not a democracy. And Michael, you and I, we know that if you took a first-year resident or medical student, there are some things that they'll probably do a little better than us at, like taking a thorough history. But if you took the reasoning, the clinical reasoning, and obviously in your case, Michael, the surgical skills, it's obviously going to be very different. So I think of AI the same way. What is it that we're comparing it against, and what is the use case? And I think the benchmarking concepts will evolve over time. And I think it'll be very interesting to see how different organizations publicly and in a very transparent way share their findings. But I think also importantly, and others are working on this, and I think Brendan, you alluded to this earlier, using open source tools allow others and invite others to go ahead and test and validate on their use cases, because I think depending on what use case you have, you might get a different set of numbers. But let's Lisa, you mentioned something about the agencies somehow, they're somewhat consistent and they're collaborative in a sense right now in terms of that. But at the Chai Summit during Stanford's AI Week, Matthew Mamoli, who's the principal deputy director of the NIH, he announced an RFI seeking public comment on the use of AI in biomedical discovery, public health, and clinical decision support. And you kind of alluded to the fact that many of these agencies are being, I won't use the word gutted, but I think that's a pretty fair approximation. And maybe perhaps they want to do more with less by using AI. They also want feedback by July 15th on how the NIH can best collaborate with other government agencies and industry on AI development and testing. And the reason I bring it up in this context now is we just talked a little bit about benchmarks and FDA. So is NIH aligning their efforts in this process with what the FDA may or may not be doing? And are they thinking the same way? Are they thinking differently? But Lisa, what is the NIH trying to do here? What are they trying to figure out and learn? And as someone, like I'm sure Michael too, we both have been recipients of NIH funding along the way and done studies. what is it that they're trying to do with this?
Yeah, well, I think the first thing to know is that very, very difficult for federal agencies to work together or to align forces. For all the years I've been working around health policy, and even working inside the government, it was really hard. So I would not assume that NIH is really aligning in any meaningful way. I'm sure that they all have. I'm sure all the agencies have the remit to figure out how they can, better implement AI in their plans for the next couple of years, right? I know that that's been the remit, in fact. I do think there's probably a question of doing more with less in terms of the NIH staff, but also truly there are real questions about, how we incorporate what is the use of AI in our national research apparatus, whatever that is today. And also, there are questions about how research data can be used for training AI models in all kinds of ways. There are questions about that. And I think it's definitely appropriate to ask, the public and ask researchers and ask specialists about this, which is what they're doing. Unfortunately, this is another RFI that is quite broad ranging, and my eyes are still bleeding from writing our 25-page response to the last one. So I need a little bit of a break, but I'm hoping I'll be able to write it at some point, working with our team at Innovacer. But really, this is. I think it's positive that they're asking for feedback, and I don't think that anything else is going on beyond just truly trying to get input from the industry and from the general public about the use of AI in research that's happening across the country. Now, a kind of a sidebar from that is I was in a couple of meetings with folks from NIH and talking to them over the last couple of weeks, both talking about the All of Us program, which is really fantastic effort to get 1 million people's really deeply connected data fully consented for use in all kinds of research. I'm one of the many participants of the study, and I've consented for all of my EHR data, I've consented for genetic data, you name it, all good. Do whatever you want, do some great research. And one of the things that came up a couple of times, something that Brendan also knows quite well, and that is that interoperability and data exchange for research purposes is like very much not built out. And a lot of that is because of the identifiable data, is because of the issue of the lack of computable consent models really across our national network. So there's also questions about how we get the data to actually do that work. And also you need that data source to be able to do AI stuff with it, right? In general, right? To apply AI models to train AI models off of research consented data for research purposes. So just to flag that there are connections there.
Yeah, I mean, I've done NIH research in the past, as well as having participated in a fundamental way with something called the CTSA, which tried to have various organizations across the country apply for research funding to have common infrastructure, or at least build out tools. The question I would have is, and maybe for all of you, is would it have made sense to go to those researchers that have taken funds over the past 5, 10 years, maybe 5 years, and ask them what would be a common set of tooling that the NIH could invest, AI, advanced technologies, and come back and say, this is sort of a roadmap that we're thinking, can you now comment on it? As opposed to your point earlier, Lisa, creating a behemoth of a RFI that's kind of all over the place in many ways. Any thoughts on that? Is that something that, I mean, I've seen it done before in other agencies where they have a small group convene and then they put out sort of a straw man type of strategy. Any thoughts?
I think they should definitely do that. I mean, I'm curious. Brendan already noted on the CMS RFI that there's always a lot of, usually thousands of random responses versus, you certainly do want to open up stuff like this to the public, but you need to get qualified responses from people who actually work with research data and work on NIH grants, right? They're the people who will best understand what is needed and what they want to do there, right? If you were a grant recipient or a researcher in general who's working with, large swaths of data and has specific needs, they're going to know how they want to use AI in their work and what they would like NIH to do or not do better than anybody else. So hopefully we'll get some great responses from people who are actually working on this. I hope they haven't written off the NIH entirely. It's an incredibly important institution for, both the US and the world in terms of fostering really important research. So fingers crossed that people will respond to this one.
Yeah, I hope so, and I certainly hope they don't feel like AI is going to replace the principal investigator or their co-investigators, or that a EHR data set with all the Swiss cheese holes is going to replace a pristine, a clinical trial data set that can be obtained only through very, very careful, painstaking time.
That's right.
So we'll have to see what happens. I know we don't have a lot of time left, but I wanted to save the most interesting topic for last. As we think about sort of the advances in AI, there was a very interesting comment that Sergey Brin had recently made, saying that artificial generalized intelligence, or AGI, would come sooner than people think. And if that's true, healthcare might be one of the most disrupted sectors for obvious reasons, things that Michael, Lisa, and Brendan, you've spoken about already. And when we talk about come sooner than what people might think, what were people? First of all, let's just establish, what do we mean by artificial generalized intelligence? And let's just go around the room. Brendan, when you hear AGI, what does it mean to you?
Yeah, I mean, I think the disconnect here is like many people hear AGI and they think of like God mode AI. They think of like the things in the movies where AI is going after Brad Pitt or whoever it is, Tom Cruise. But it's not.
I'm dating myself with Skynet, but
yeah, Skynet. But Skynet is timeless because they keep making terrible remakes.
That's true.
But AGI, the definition that I think is gaining consensus is pretty good, even though it comes from Keith Rabois, is that it's ammunition. It's the things that can be given a task and trusted to complete it at a good enough rate. Whereas artificial superintelligence is this like God mode, like, does things that humans can't. And so in that light, can an AGI fulfill tasks, a series of tasks that a human in a certain role could? Well, shoot, like it does seem like we're really close to that in certain roles, in certain capacities. And if you're doubting that, then I think you're probably not looking at some of the cutting edge stuff that's out there. But so I think that's the disconnect, is just a definitional one.
Lisa, Brendan gave us an interesting definition of AGI. Anything you want to add?
Yeah, well, as someone who trained in cognitive science, I would say, I don't really buy the theory of mind definition. I don't sort of filter down the synapses firing in my brain to be like a computer. I don't think my brain is a computer in any way, shape, or form, or even just a neural network. It's much more than that. So I think we would all be perfectly well suited with an AGI that can do a lot of the tasks that we expect. But I also think that specialization is so incredibly important that I don't think it'll be very relevant. Like there will be AGI-like options out there that can do some of the general things that we expect, probably very slowly, and there will be lots of very specialized intelligences that can do a lot of things very quickly. So that's how I kind of break it down. I don't believe in God mode in any way, shape, or form. Maybe someday in the future I'll be proven wrong, but I personally doubt it. AGI is generalized intelligence, but more important will be the many specialized intelligences working on our behalf.
Interesting. Michael.
I like the specialized intelligence pathway here, right?
Well, you're a specialist. I mean, of course you're gonna like that.
I mean, and I think that's a super interesting way of looking at it. I forget who it was that shared this with me, but language, reasoning, agency, innovation, organizations, right? And so and I feel like if those are the traits that one needs to have in order to have AGI. But where I get a little bit of the heebie-jeebies, right, is when you take a human being, or you take an AI that has language, reasoning, agency innovation, and you give them access to unlimited fund of knowledge and perfect recall, right? That's where you're getting. So can you? I'm and maybe this is just the urologist in me, but how do you reconcile that the AGI that we've just created with the superhuman recall and superhuman fund of knowledge, right? Because
Sure.
how do you not get super intelligence from that, right? And so I do think that we're close. I agree with Brendan and Lisa. But I am curious how you separate AGI from the super intelligence that Brandon's talking about, right?
Yeah.
Because that fund of knowledge and that recall, I mean, I don't remember what I had for dinner yesterday, right?
Yeah.
I mean, I can guarantee you that AI will remember what I had for dinner yesterday.
Yeah. So look, guys, I mean, my first neural network project was in biomedical engineering school back in 89, 88, 89. I would run the neural network on a Mac 2FX at like 4 o'clock in the afternoon on a Friday, hop on the mill, and I would pray that there was no errors over the weekend. And on Monday morning, I would look at the output, and I would do that over and over again until we got a publication in the physiology lab at Northwestern. There's no doubt that compute and storage have come a long way. And to your point earlier, Michael, if you got enough storage, you got total recall, right? And I think if you have enough compute and you can start to do this, and as a biomedical engineer, training, I would argue, Lisa, that it'd be very difficult to separate out, other than some of the spiritual aspects of what we do, what makes us human. The neural network in the brain is phenomenally similar to the neural network we might create in a computer program. And so I don't know whether the specialized ones, I think the specialized ones will come much quicker. But I think the holy grail is the generalized intelligence, which is I don't have to train you to do urology or internal medicine, but I can give you a set of problems and you can reason through it and come up with an answer. The artificial generalized intelligence, I think, will come. And I think there's some consensus among experts that I think it's shrunk down from decades away to now by the end of this decade to maybe even, as Sergey says, by the end of 2026. I think that's pretty far-fetched.
2026, that's stretch. That's a little bit of a stretch.
Yeah, it's a little far-fetched because I think there's some other forces at play. Any form of advanced technology, maybe get your perspectives on this. There's going to be barriers. There are going to be barriers from a regulatory point of view. Can you imagine? What the AMA might ask, or the medical boards might ask, if Michael, you wanted to take on a artificial generalized intelligence to do all your H&Ps before your surgeries? They're going to ask you, well, wait, hold on a second. What is this? What credentials does it have, and all that? So I think there's a technology angle to this, but there's also societal and a socio-technical aspect to forces. I'd love to get your perspective on that. Separating out, can we do it technologically from a societal point of view, and from a,
Yeah.
what do you guys all think about that?
Well, I have one barrier that is very in front of us that is definitely going to slow down AGI, and that is we have this tremendous and deep lack of interoperability that is intentional and competitive and based on financial incentives or disincentives that exist, right? And so having access to the full fount of knowledge is very, very challenging. It's very challenging for any doctor, two doctors right here, to even access all the relevant data on a particular patient in front of them at any given time. And so, there are some structural barriers to accessing the full font of even knowledge about a specialized topic. So that's the first thing I would say. And then to answer the rest of your question, on the societal thing, we just don't currently have the social structure, safety net to support that. I love the future where humans are not required to do a bunch of really tedious manual tasks, but we do have to create alternatives like people doing, caregiving jobs that are not, about that are about, human connection versus about, really hard physical labor, right? I love us being able to advance knowledge and learning and art and all those things while the robots work for us, but there's a lot of pieces, a lot of steps between here and there that I think are barriers to that.
Yeah. Michael, Brendan, any thoughts?
Getting a full picture 100% will never happen. And so we have to get as close as humanly possible, which is the job of Lisa and I. Like, that's all we fight for, the good fight in health information exchange. But we have to presume that we have incomplete information, and that there'll be some random Colorado clinic that's on paper still, that there's, there's something missing. And so, like, with that assumption in mind, we can build resilient AI and build resilient tooling that is just 10xing, 100xing the things we can do, even though it's imperfect.
Michael.
But I'm going to go back to something that Anil said, right? It will never get to perfect, right? Just like you said. And it's always been imperfect. And I can say that what we had before was far less than perfect, right? If we look back to paper, we look back to pre HIE and Kafka and what have you. It was far inferior. And so I think that any decisions that you make based upon the data that is currently interoperable and will be interoperable into the future, it is going to be way better. So again, it is it better than the median decision from 15 years ago? Oh yeah, right. And so I think it's I think it goes back to what Neil said. What's your benchmark? What's your benchmark, right? And if you don't have access, right? If you live in a healthcare desert, right, and you don't have access, then you know what, that median AI or that median is better than what you have, which is nothing. So I think that, and what Bill Gates says, that we always overestimate what's going to happen in 2 and underestimate what's going to happen in 10. So I think that hedging our bets and saying that AGI will be around in 5 years is probably a good bet.
We should start preparing for what our jobs will look like when that happens. All of us who think for a living at times might be replaced. Michael, I think you're good, right? Because you're a surgeon, so we're not going to have any robot doing surgery, are we?
The latest technology out of Intuitive Surgical is pretty amazing.
It is.
It is pretty amazing. And so eventually, if they can piece together all the steps to a surgery, yeah, it is. I don't think that they're that far away.
Yeah, absolutely. Well, this was a fascinating conversation. Michael, Brendan, Lisa, thank you so much for a lively discussion. I hope our audience learned quite a few different things, and we welcome you to tune in to our next